Hi, my name is Elizabeth Campbell. I am a physical therapist with Limitless PT here in Cortland, New York. I am a pelvic health as well as orthopedic and sports physical therapist. And here at Limitless, we treat both men and women for pelvic health conditions. This presentation was created to provide some just initial introduction education about some of the different pelvic health related conditions that we treat in pelvic PT, and specifically shed some light on pelvic organ prolapse and really what the role of pelvic physical therapy is. Here at Limitless, we are on a mission to grow a really thriving community that inspires the best possible health outcomes. And what we experience in our clinic, especially with women with pelvic organ prolapse, is a significant impact on not only their confidence in participating in exercise and wellness, but their overall comfort with movement and participation with physical movement. As we know, this is incredibly important for longevity and long-term health. The reality is that 1 in 8 adults, men and women, will experience pelvic floor dysfunction in their lifetime. And in general, there is a lower familiarity or lesser familiarity with pelvic PT. But really all pelvic PT is a rehab that focuses on addressing those symptoms of pelvic health dysfunction while moving the needle on improving an individual's strength, mobility, and those foundations of health and wellness. And so those women who kind of fall into that category of experiencing symptoms of pelvic organ prolapse are definitely appropriate for pelvic PT and would benefit immensely. So we're going to talk about kind of the what and why of pelvic organ prolapse. We're going to talk about how pelvic floor PT is helpful and kind of what the goal and mission of pelvic floor PT looks like here at Limitless Physical Therapy. So in talking about pelvic organ prolapse, right? So this is essentially a global term that describes mobility or descent of a pelvic organ relative to the vaginal canal or vaginal smooth tissue. So that being said, we can appreciate that there's multiple pelvic organs, right? We have anteriorly the bladder, and then we have kind of superiorly the uterus, and then posteriorly the rectum. So not all POP presents the same. Not all pelvic organ prolapse should be treated the same. Generally, the definition that we use is that there is a loss of support of one or more compartments, whether that's that anterior compartment of the bladder, that superior compartment of the uterus, or that posterior compartment of the rectum. And due to that loss of support, you get mobility of that respective organ against the vaginal canal. Grading is typically done on a 0 to 4 stage assessment. We perform this assessment in our evaluation process, both in a recumbent position in laying as well as a standing position to get the full effects of gravity and body weight. And I think the big piece here in understanding POP and thinking about POP is the symptom behavior. So most women will report some sense of heaviness, some sense of pressure or descent. Some women may even feel some deformity if they are palpating around that perineal area. When it comes to the occurrence of pelvic organ prolapse, it's pretty common. It's very common. So 50% of women will objectively be examined and demonstrate a pelvic organ prolapse. So that kind of fits into this category up in the upper right, where they're reporting symptoms, positive symptoms subjectively, and positive symptoms objectively. But there are many women who are examined for prolapse who don't experience symptoms. So their objective assessment is positive, but they themselves subjectively are not experiencing any symptoms of heaviness, descent, or pelvic dysfunction. So this is really interesting, and we like to refer to POP as almost prolapse is like the disc bulge of pelvic health, right? If we think about the statistics around the disc bulge in the spine and how prevalent that is, especially as people are aging beyond that age of 30, we really see prolapse has a very similar tendency and trait in our research and in our findings, that it is very prevalent, with over 50% of women having an anatomical prolapse, but it is not highly symptomatic. So about 3 to 8% of women actually experiencing symptoms of prolapse. Now, the rates of prolapse, of an anatomical prolapse, increase with subsequent vaginal births and deliveries. So we see that increased likelihood of 4 times to then 8 times more likely to have an anatomical prolapse when you go from 1 vaginal delivery to 2 vaginal deliveries. But again, this is just a reflection of what's anatomically being assessed, but doesn't take into account but is not accounting for subjectively what a woman may be experiencing or reporting symptomatically. Oftentimes, we'll have women reporting these symptoms in correlation with a recent pregnancy or postpartum recovery, as well as in that peri-postmenopausal time frame. So when is treatment indicated for prolapse? And the big one here is symptoms. If an individual is reporting symptoms of pressure, of heaviness, of some sexual dysfunction, of urinary dysfunctions and or bowel dysfunctions, along with that symptom of heaviness or descent, those are really great indicators to refer or to consult with a pelvic floor physical therapist. And the first line of treatment here is addressing some specific lifestyles. So if we think about the nature of prolapse being descent and pressure, then we want to do our best to address that pressure and stress that's being placed downward on the pelvic organs. So we're going to talk about avoiding straining, which comes in the form of physical activity as well as our bowel health. We're going to talk about incorporating the use of a pelvic floor co-contraction. We like to refer to this in PT as the knack, but it's essentially a way to co-activate or activate the pelvic floor in synchronous timing with a high pressure or physical activity. So for some women who are symptomatic With a cough or a sneeze, we will cue them to do that pelvic floor contraction. With some women who are symptomatic with carrying heavy items or lifting or squatting, then again, we will cue them to perform that co-contraction of the pelvic floor. The other piece here that's really important in management of prolapse is treating and avoiding constipation. And this is really significant, as constipation can create a really incredible ripple effect of pressure and stress within the pelvis and along the pelvic floor. So a big key right away in pelvic floor rehab is getting an idea of someone's bowel health and addressing those symptoms or dysfunctions right away. And then fourthly is having the conversation about weight loss. That is a objective correlation with objective correlation with an individual experiencing symptoms of prolapse or pelvic heaviness. And what the research tells us is that as a woman's BMI decreases within healthier ranges, they experience less symptoms of pelvic heaviness. The other kind of big step and first line of treatment is building strength and building capacity. And I would say most of the time when patients come in and hear this, they are immediately caught off guard, because to them, it makes sense. Like, if I'm having something prolapse or descending, I don't want to add more pressure. So I am not going to lift. And therefore, doing intentional lifting exercise just doesn't make sense. But think about it. In our day-to-day life, and especially for a new mom or a grandma, they're going to be lifting, right? They're going to be lifting children, carrying children, moving things around the house, food shopping, and they want to exercise and need to exercise. So it's not really a matter of is exercise and lifting good or bad, but can we train you to do these things more efficiently? Can we train your muscles to be more efficient? And that takes pressure off of the pelvis. Can we train you to breathe better while you are exercising? And that removes pressure across the pelvis. And can we just make your muscular system more robust, your general fitness more robust, so then you can go and move and lift and play with your children without feeling or creating unnecessary strain down on the pelvis. So the role of pelvic PT is we're going to do a lot of very pelvic direct treatment. We're going to assess the pelvic floor and what its current functional state is. So what its tone is like, what its strength and endurance is like, and what its coordination is like. So how are these muscles behaving under pressure, under strain, under stress? How are they being recruited? And can we address one or some of those features? We're also then going to work on pelvic floor indirect. So that is where we're focusing in on your bowel health. We're going to focus in on your breath control and your pressure management through your torso, making your abs more efficient, making your breaths more efficient. And kind of getting the entirety of that torso, or what we like to call the core canister, to work more efficiently. And when that is more efficient, that is less strain down onto the pelvic floor and your pelvic organs. And then, like I mentioned, we are going to work on improving an individual's general fitness. A lot of it is just slowly raising the bar steadily to bring along the pelvic floor, to bring along an individual's load tolerance, so that by the time they leave and are finished with PT, their original report of feeling pelvic heaviness while just holding their 10-pound baby turns into no pelvic heaviness with squatting their 50-pound child. So this is, again, a tricky thing for patients to initially conceptualize, but once they get moving and are building capacity within their core and their hips and their legs, they just feel such an immediate difference. So within a PT evaluation, we're going to do an orthopedic assessment, meaning we're looking at their hips, their spine, how these systems are working together with their pelvis and their pelvic floor. We're going to do a loading assessment, meaning if patient A reports their symptoms occur when jumping, I'm going to have them jump and see what their baseline capacity or threshold is. I'm also going to see what their form and their technique and their mechanics are like. We'll also include a bladder assessment using rehabilitative ultrasound, which allows us to get a really nice initial look at the pelvic floor muscles and their impact on the bladder, and then go into a pelvic floor examination as indicated. And again, for our pelvic organ prolapse patients or patients who are reporting those symptoms of heaviness or descent, we're going to do this assessment again in a recumbent position and again in standing, so that we can factor in a truly functional load of gravity and body weight. And then we will definitely capture features of a bladder diary, a food diary or bowel diary, and try to optimize some of those lifestyle features of their water intake, their nutrition, stress management, and their general exercise and wellness capacity. So this was just a little bit of intro information, but I hope you find it helpful in thinking maybe about some of your patients, or if you are an individual experiencing these symptoms, in kind of shifting maybe your thoughts around these symptoms and hopefully seeing the great and incredible role that pelvic health could potentially be for you. So if you have any follow-up questions regarding this information that was reviewed today, or if you have patients that would be appropriate for pelvic PT to address these symptoms, or if you are an individual with these symptoms, please do not hesitate to reach out to us. Our information is below, and you can also find us online. Thank you.